Hello, Assalamu alaikum and good evening. Welcome to another episode of Health is Wealth. I am your host, Shabnam Riaz. How are you on this Saturday evening? Hoping that you're having a great start to the weekend. And as usual, we're here, as we are every week, to guide you about all those, aspects of our health that we should really be on top of. We try to separate the myths from the facts in this program. That's why we have our experts here. And we try to tackle all those issues of health that are really, really important. Today, we're going to be talking about interventional cardiology, and the theme is your heart and your life. And for that, we are very happy to have with us in the studios Dr. Amjad Bhatt, who is an interventional cardiologist, and he's here in Pakistan. He's been in the US since the last 38 years. Thank you for joining us here today.
Pleasure is mine.
Okay, and viewers, in today's program, what we're going to try to do is we're going to talk about all those things that, maybe we just don't realize. Maybe we're in denial, and the importance and the impact of the health of your heart and what it means and all the things that are related to it. Those are the things we're going to talk about. Now, before we go on to other aspects of today's subject, what exactly is interventional cardiology?
Simply, the one who intervenes in a problem.
Right.
In simple words, the one who puts stents, angioplasty, pacemakers, defibrillators. So just somebody comes with a heart attack and you intervene in their well-being, because heart attack can kill you.
Right.
So we just take them to cath lab and open the blockages. So that's what interventional cardiology is. It encompasses a whole host of other procedures. My specific interests are heart failure. So there are a lot of things which we can intervene for heart failure. Peripheral disease, because diabetes is very rampant throughout the world, not only in Pakistan. And you must have seen a lot of people walking around with amputee limbs.
Yeah.
That's where we can come in and we can save, or we can salvage the limb without surgery, just going in with the catheters and wires and opening the blockages.
Right.
Oh yes.
Okay.
Actually, just very recently, a couple of weeks ago, the gentleman had a blue toes. I brought him to the cath lab, and he has a blockage right close to the ankle, completely blocked, and we were able to open it very easily and quickly to restore the blood supply and save the limb. So
Right.
that's where the intervention comes in for interventional cardiologists, because my training is cardiology. So I intervene. There's a clinical cardiology, the people who don't do any specific procedures. There's an electrophysiologist, the one who deals with the electric system.
Right.
I call myself plumber of the heart.
A plumber of the heart. I like that.
Because we open, it's a rotor-ruler, so to speak.
Right.
We open the blockages, like the plumber will open the blockages in your pipeline. So we use this common
very simple way of...
simple way in states even.
Okay.
Electrophysiologist is electrician of the heart, because it deals with electric system of the heart. And I'm a plumber. I deal with the pipeline.
Fantastic. Okay, so that is really interesting, the way you've put that. You see, once a person can sort of visualize what exactly the problems are, because people who are not from the medical field, they'll find it hard to understand what exactly is going on in the body. And the way you sort of described it, that, your plumbers of the heart opening up and relieving it of the blockages. So, many people do not understand the importance and, what blockages actually mean for the health of your heart. What blockages, what different types are there, and what should a person be concerned
Yeah,
about?
there are different types as well. But for the common person, we have a blood supply of the heart. And there's a specific names, we're not going to go into that. When the plaque, the common word, you must have heard plaque, which includes your red blood cells, your platelets, your cholesterol, your calcium, fibers, it's a kind of a heap of junk.
Debris, sort of.
Debris, which is enclosed in a cover.
Okay.
A layer on top of that. When that layer, that cover, breaches,
Right.
it's exactly like a lava. When
Okay.
it bursts open, it throws out everything into air.
Okay.
And what havoc it plays, you know that. The same thing can happen when that debris comes out. It's going to plug the blood flow.
Right.
Blood carries oxygen. And when there's no oxygen supply and nutrients to your muscle,
Right.
heart is a muscle.
Right.
When there's no nutrients or oxygen supplied, the heart is going to die. That muscle portion is going to die. We use a term, the time is muscle. It means the timely intervention is very crucial. Otherwise, if you delay that treatment, management, if you delay that intervention, the heart, that muscle portion can die permanently.
Right.
That's a scar.
Okay.
And then the whole host of complications
Right.
will erupt from that death of that, because cell, cell death. So it's a multiple cells, billions of cells, which make that muscle.
Right.
Ultimately, when those cells die, that portion of the muscle dies. That's useless for the function of your heart.
Right.
So that's why it's very important that you intervene immediately, very quickly. And people have to understand that.
Right.
Just don't sit home. Because to have a couple hours in emergency room or with the doctor can save a lot of years of your life.
True.
Death is not the only endpoint.
Right.
The
Exactly.
complications which you're going to live with, which you're going to put the family through, are more important. Death, you die, yes, mourning, groaning, sadness, for a limited time. It's over. You're gone. Family is back to their life.
Right.
What about if you have a stroke?
Yeah.
If you have a damage to your heart that you can't even function? So your family is stuck with you. Your loved one, they cannot put you out on the street.
And your quality of life.
Of course, because of the poor quality of life, your family. I always tell my staff, I will not spare you if you are not cordial and respectful to the family. The real sufferer is the family.
True.
Because patient has no choice to go through the needles, to tests, surgeries, knives, everything, the medicines. The one who have choice, but they can't leave their loved one. So they really suffer.
Right.
So it's very important when the patient comes in that you involve the family. To educate the patient is as important as
Educating the family.
family.
Right.
Because if they are not educated and you're telling them something, they will not understand.
Right.
It will disrupt the family atmosphere. It will disrupt the family dynamics. So that's why every patient should have one or two family members who can understand. And I try always to come down to their level.
Right.
I try to avoid using terminology,
That they can't understand.
even when they are educated, because they haven't gone to medical school.
Yeah.
They be educated, but they don't have the knowledge of terminology.
Absolutely,
So I don't choose. So I try to find simple words where it can make sense. I don't need to scare them, but I want to be assertive enough so they can pay attention. They pay heed what I'm trying to tell them.
So they're taking
because
things
they
seriously.
don't know what the consequences can be.
Right.
I know. So it's my moral responsibility, other than professional responsibility, that I do interject and teach them and tell them in an assertive way, not a disrespectful, not a yelling way, as a friend, because your doctor is your best friend, the one who takes away your pain.
Oh, yeah.
Who can be better
Absolutely.
friend?
And you know, you have so many instances when you see a doctor, and a doctor who has cured you for something, as you just said, you know, pain or something else, you do say to them, oh, you know, prayers just came out for you from the depth of my heart because you cured me for something. So that's how much trust you put into your doctor.
Cure is not even into the pipeline, because you don't cure everything. But you manage to make their life functional and comfortable. That's what you need. If you have a migraine, for example, I don't think I can cure your migraine, but I can timely intervene and take care of that migraine so you can go on with your function, with your work, with your life.
Right.
So cure is not basically the end point.
Right.
The end point is how I always tell the family and the patient, my goal is you come here on this bed and you go home walking on your feet. You can go to bathroom.
With a better quality of
You
life.
can go to shower. You can eat yourself. Somebody doesn't have to put a piece of meat in your mouth or a spoon feed you. So functional life, productive life is very important. You go back to your work. If I'm sick, God forbid, somebody's going to take care of me so I can go back to my work.
Right.
Cure, suppose somebody's diabetic. I can't cure him or
Right.
her.
Right.
But my job is to stop the progression of those complications, or slow down the progression,
Right.
or stop there. So they don't have the consequences of this basic pathology, diabetes. Because sugar is in every cell,
Right.
and we are made of every cell,
Right.
from hair to toenail.
Right.
So sugar, diabetes is going to involve an effect from hair to toenail.
Every single part of your body.
Every single cell of your body. So this means you can have a stroke,
Yeah.
blindness, heart attack, stomach problem, your legs, amputations, circulation problem. You can't walk. If you cannot walk, how you can function? Because the moment you're going to walk, you're going to have a pain.
That's how serious diabetes
Of
is.
course. You know, I always tell people this is a sweet cancer.
Sweet
Even
cancer,
back in
okay.
States, this is my pet statement. This is my phrase. This is a sweet cancer. You can cure breast cancer. You can cure colon cancer. Can you cure diabetes? I don't think so. You can manage it.
And you see, if I just tell the viewers who are watching the program, this is how important it is to manage diabetes. If you are diabetic, you can't take it lightly. You've got to be ahead of your disease. And those people who are pre-diabetic as well, because I think it mainly happens a lot in our part of the world, that we're a bit too casual when it comes to, our health. And we just take things a bit too lightly.
I think instead of, thinking that people are not paying attention, there are many other factors. Education is the basic factor which is lacking in our population. 60% of our population in rural areas, although some of them are educated. But then the resources of getting that information,
True.
then the resources to manage, because financial issues are the biggest issues in our society as well.
Yeah.
Because since the time I came to Pakistan, and I started realizing, because in the beginning, it was shocking for me, somebody talking money in front of me.
Nice.
Many times, I stopped my staff. I said, I'm not used to it. Please don't talk. Patients ask me. And I said, sir, I don't have a retail shop here. I don't know. I don't talk money. My job is to take care of you. But they are right in their own rights. They have to pay. They have to sell some of their properties or houses. I have seen people
It's a
selling
very
their
real
houses
concern.
to
Yes,
pay for it.
absolutely. Yeah.
So we have to be cognizant of all these factors when we come across a patient. So that's why education and preventive medicine should be the norm in Pakistan.
Preventive
As
medicine.
that
Yes.
is lacking, because
Yeah.
this is the primary prevention, that you intervene before it happens.
Exactly.
For example, I give you an example. In heart failure, which is my personal interest, besides peripheral disease, we used to use NYH class, 1, 2, 3, 4, 5, 4. Now the new class, which is a functional class as well, A, B, C, D, right? You are at the class A, stage A, but still have a heart failure. But stage A means that you haven't started the pathological changes in your heart, which is abnormality. So my goal should be, my patient should not transfer from class or stage A to stage B.
Okay.
I should do everything with the consent of the patient, of course, because I always tell patients, you're the boss. If you don't allow me, I can't do anything. I can't even touch you. Because this is your body, this is your life, this is your right. Not privilege, this is your right. That you allow me, to permit me to treat you.
Right.
So my goal should be, how I can keep this patient at stage A. If not permanently, but as long as can
be possible.
So he doesn't go into stage B, because once you're in stage B, you already have changes, damaging pathological changes in your heart and, of course, in your body. And then if you go stage C, the game is too late. So this is how we have to make our patients and families understand what my goals are, why I'm telling you this one, why I want to do this one. If you don't, another thing you must have observed, and I have seen here, sir, please don't tell it to my mother or my father.
Yeah.
There was a young man,
Yeah.
I say, beta, please, come here. I say, who's going to have surgery, you or your father? Or my father. Who's going to have pain, you or your father? My father. Who's going to get medicines and take medicines? You or your father? My father. So I said, don't you think he should know what's going on with him?
Exactly, yeah.
I can't be a liar. I have to be truthful to your father. Yes, it'll be difficult for him to, in the beginning, upfront.
Yeah.
But believe me, then he will accept it.
And then he would have said as well, you know, in the beginning, he could have any time said to the doctor that, you know, why wasn't I told about this?
Exactly.
Because
So-
that shock is also something
Exactly.
that will
Of
make
course,
it harder.
Patients need to know
Yeah.
what's going on with them, even at the deathbed. You have to be very diplomatic, of course. You cannot be
course.
crude.
Yeah, yeah.
You have to be, you know, passionate, and you have to be compassionate to talk to the family, because they're very tough times. And yesterday there was a gentleman, old man, and I very politely told him, this is what I think, but I can't play God. And ultimately, he passed away right away, you know, within moments. But you have to be, because it's an emotional issue.
Of course.
That's his father. And I made him realize that I understand that this is your father, and I am aware of it. It's a very emotional issue.
Of course.
Yes, we have a patient right now, young man, and that's the only son. So we are very, very careful when we talk to the family about it,
Of course.
because you cannot be negative.
Right. You spoke about emotions. How much do emotions affect the heart? Is it possible for people to die from a broken heart?
I don't know what is broken heart, but that's kind of different connotations. That's
Enduring a trauma?
That's a
or-
social issue.
Yeah, okay. A trauma.
Not a medical issue. But
or
if we
an
talk-
emotional state.
Oh, yes, of
Yeah?
course, because heart is under nervous system control as well. And autonomic nervous system has two wings. And the autonomic nervous system is under involuntary control. You must have seen you're fearful or you're scared, your heart goes up.
Yeah.
You're angry, your heart goes up. The rate goes up, blood pressure goes up. That's not under your voluntary control. So yes, if you have a trauma, a bad news, you know, the same gentleman which I told you, when his father found out, because that's the only son, 23-year-old, very handsome, his father had a heart attack.
Oh,
So yes, because we are human.
Yeah.
We are living soul. And we react. And that reaction is inherited in us. It's
Right.
inherited in us. If we don't, then that person needs a psychiatrist.
right. Of
So
course.
emotion, yes. But broken heart, I don't know. I don't have experience.
Okay, right. You spoke again, about blockages as well in the beginning. What do people need to be mindful of, and what health conditions place you to be more at risk for developing a blockage?
I'm glad you raised this question. When I see a patient, I'm going to give you how I approach so people can understand.
Right.
I see a patient, and I don't see a patient with a focus just on a patient. I have to see patient as a whole, all peripheral.
Okay.
So you cannot block your peripheral sight. You have to see, and then you read your patient. I always tell my students, patient is your open book.
Okay.
Read the patient.
Right.
If you don't read the patient, and that reading starts from the handshake. I always sit on patient's bed. I don't sit on the table when I go to see a patient downstairs.
Okay.
In the ward or ICU,
Okay.
CCU.
Right.
I sit on their bed,
Okay.
rub their hand, shake hand, to generate, to create the rapport, that friendship,
Trust.
that trust,
Yeah.
that confidentiality you're going you're going to share with each other. Then the patient opens up. You see a patient, you see their gender, you see the age, and you see the non-modifiable factors. That's genetics. You can't modify anymore. You're born with those traits. Your parents, your grandparents have given you, transferred those traits. You can, but then you see the factors which are modifiable. Your weight is modifiable.
Right.
Your lifestyle is modifiable.
Yeah.
Your blood pressure is modifiable.
Right.
Your sugar is modifiable. Your cholesterol is, your eating habits, your living habits, your exercise habits. This is all modifiable risk factors. And we use the term deadly quartet. And I have mentioned that in the previous program here. Deadly, of course, is an English word, and quartet means 4. So if you have 4 risk factors, your mortality morbidity is very high. The chances and probability is very high that you can die based on those risk factors in concert with your symptoms. I can tell you this is the chances of you having a heart attack. For example, somebody, a male gender 40, even with the atypical symptoms, I'm going to talk what are typical and atypical symptoms, can have 40% probability of having coronary disease, meaning blockages. Just atypical symptom, just being male over 40.
Just being male over 40.
Just being male
Okay.
over 40.
Okay.
And now add his weight,
Okay.
belt line in particular. Now, American College of Cardiology and American Heart, our board of medicine, where I practice, there are specific forms they send me that you have to document the waistline.
Right.
This is that. Obesity became #1 risk factor in coronary disease. And how many people are walking around? Double chin in Pakistan is a sign of health. Double chin in America is a sickness.
Right. True.
See the difference?
Yeah.
And that's because of the awareness. Unfortunately, the governmental resources are not enough for education. Otherwise, you go in states, you have billboards all over,
Right.
making you aware. Every driver can have a peak. So if that person, 40-year-old male, comes with a chest pain, and if it's a classical chest pain, that I have a pressure like a burning or squeezing, or somebody sitting on my chest, sometimes people say, elephant sitting on my chest.
Okay.
And then I got a little dizzy, I got weaker, sweating. These are classical symptoms. This pain was going here, pain was going here, sometimes just atypical, just tooth pain.
Just tooth
Pain
pain.
here. There was a cardiologist who was having toothache, went to a dentist friend. He says, everything's normal, get an EKG, he's having a heart attack.
Oh.
And I have just recent experience, the guy comes with a heart rate of in 40s and 50s, which was not the case in his case. And he said, just gas. I have to spend 2 hours to convince him because he happens to be from a medical field somehow. And he said, no, sir. He left emergency room despite my begging. I said, sir, I have to explain why your heart rate is low. You're having this, and this is, to me, your right side of the heart is affected. And to make story short, ultimately, I end up putting 2 stents. He has a complete blockage of one artery, complete blockage of other artery. Then I asked him, you want to go? It's not your heart?
Yeah.
So we come across these people.
Okay.
So the same patient, age 40, comes in with the classical symptoms. On top of that, diabetes. I don't have to know anything more.
That's it. And then you're just
It's a
clearing.
99% your heart attack proven otherwise. When you are diabetic, my antennas go up,
Okay.
even with the atypical symptoms. Why? Because I always tell patients, I want to rule out something which can be consequential,
Okay.
which can kill you,
Right.
and the heart kills. Once that's ruled out, all nuances, pain here, air, gas, all that, I can treat. You're not going to drop dead.
Yeah.
Last night, a patient of our CEO's friends came, and I said, I'll keep you. 99% I don't think this is your heart, but I can rule that out. She's diabetic. I kept her. Then I told her everything's okay. EKG. And so, to your surprise, I can have 5 to 10% of the patients who are having heart attack but they have a normal EKG.
And they have a normal EKG?
Of course.
Okay.
So when people come in, doc, I would just examine, and this one's normal, this one's not. Yes, you are sitting comfortably. EKG is going to be normal, unless there were some previous problems which will show in EKG. So don't go for that.
Right.
Clinical intuitiveness. I tell all the junior students or medical officers that keep your eyes open.
Look at the whole picture.
Read your patient. Don't take for granted.
Right.
Otherwise, you'll miss the boat. I give EKG, for example, and they diagnose because, they are just excited. I say, you just failed. I don't want the diagnosis. I told you read your EKG because you have missed so many things. And you concentrated only on one, big one, which you could see, but you missed this many, many other things. So until and unless they read their patient, they will miss. So it's very important for the physicians, particularly the junior ones, as well as the population and the family, that don't miss. In this, the most important and the crucial factor, I believe, in our society, in our part of the world, is doctors either don't allow or patients not tuned or are trained to ask questions.
Yeah.
When you go there, they see your life.
Exactly.
As
You should, in fact, before you go, have a list of things you want to ask your doctor.
In matter of fact, I remember one patient distinctly back in States. She has 4 daughters. He has 4 daughters. They used to come with a pen and paper in their hand. And no matter how long it takes, I have a habit to answer every question, no matter how unrelated. Because patient wants to ask, that's your job, to answer them.
Right.
Don't shut them up. Because otherwise they'll feel empty. Like, we wish this could have been answered. So they used to come and write everything I say and every question they have. So, and to your surprise, being a cardiologist, I diagnosed that he has a colon cancer ultimately because his primary care missed it.
Because of all the questions you were asking and all the time you were taking.
Because then there were certain things. For example, no doc, because of my dentures, this is a patient telling me, my dentures, I'm not eating well. I said, sir, I have to explain to you involuntary weight loss. I couldn't. So let me get this test. And here we go. He has a colon. And from there, we were able, because this patient died because it was too late. But at least we diagnosed.
Yeah.
From there, I was able to save another one. God saved. I was able to diagnose another one. So you have to keep your eyes open, your faculties open. Our students, our doctors need to know that they need to be clinicians, not doctors.
Right.
PhD is also called doctor, but they're not clinicians. A clinician is what we're just talking about.
Right.
Sit down with the patient, talk to him.
Bring in the whole picture.
Exactly. And
look at the patient as a human being.
They are human beings,
Yeah.
but look at the patient as a whole. Let patient vomit out everything they have in their head because that's what they want to do. That's what they came in for.
Right.
Giving medicines, you can say, pharmacists know more names than me. My nurse knows more names. I'm actually learning names in Pakistan. But 38 years I spent in the States. I'm tuned to those names.
Right.
So I'm learning. So if giving pills is art of medicine, I don't think so. Then the pharmacists and nurses can give, better, probably more, bigger list.
Right.
Medicine is what we're just talking about.
Right.
It's an art.
Right.
It's a science. And you are equipped with that knowledge. You have to share because you cannot, if you don't, stepwise. And intuitiveness, based on your knowledge, based on your current evidence, based on your experiences, that you simulate that knowledge. And that's how you evaluate your patient. Bring all those faculties into play. And then you make up your mind that this is what's going on with the patient.
Right.
It may not be correct 100% the first time, but this is sometimes we rule out diagnosis of exclusion, that you keep on excluding because sometimes the diagnosis is right there.
Right.
Sometimes you have to struggle to find that, and that's where your intuitiveness comes in. That how you have evaluated the patient. But if you have not even evaluated the patient, I don't know what's going on in your belly. I don't know what's going on in
Until
your
they
neck,
tell you.
unless I don't know what's going on in your lungs. So you have to have your findings, simulate those findings with the symptoms, and then the risk factors. Know you have encompassed the whole patient, and you have come to a conclusion. In my opinion, this is what's going on.
That's a whole strategy.
Of course.
You know, that very
I
detailed
always say
one.
I don't treat patient,
Yeah.
I manage patient.
Oh, fantastic.
Management is different than treatment. Treatment is giving pills. People tell me, what should I eat? I say, you're allowed to eat everything. Reschedule your eating.
Right. That's something that every patient would want
I
to
mean,
hear.
if I have a closet,
Yeah.
I shove my clothes, I will fill the closet in no time.
Right.
The same closet, same clothes, if I dress them up, I'll still have a lot of space left.
Right.
What I did, I
Just
just
arranged them.
rescheduled,
Yeah.
rearranged them.
Right.
And that's what I tell them. I say, you walk every day. Rearrange, reschedule your walk. No, it has to be a brisk walk. It has to be scheduled, timely walk.
Right.
That's your time. You eat every day. Instead of big steak, eat small steak.
Right.
Instead of every day, start eating every week. No deprivation of
And
goodies.
in fact, that makes more sense because
Of course.
psychologically, when somebody says that to you, you just feel, okay, I'm fine. Okay, really, if I can do that, it seems more manageable.
Because I know they're going to cheat.
Exactly.
So why don't I allow them programmed cheating? This is my strategy.
That's
this
true.
is over.
Because-
Because I know they're going to cheat. I
Yeah.
allow diabetics to eat cake, but not every day. Just to quench your thirst, your
Exactly.
taste. Eat once a month, no problem.
Otherwise, psychologically, when you are told you can't eat something,
They're gonna cheat.
the attraction towards that
They're
certain
gonna
type of
cheat.
food is yeah,
Believe me, they're going to
increased
cheat.
anyway.
So allow them to cheat.
Right.
But it's
Within
scheduled.
sensible,
Exactly.
within sensible limits. Okay. We were talking about blood pressure as well before we were recording the program, and something that you said, you know, that I thought was really motivational. You said that 5 mm reduction in blood pressure would actually decrease your mortality by 5%. So I think that is something that the viewers need to hear as well.
I'm glad. This is such a common. We use a term, triple paradox. What it means, blood pressure, you just mentioned, easily diagnosable, remains undiagnosed. Number 2, easily treatable, remains untreated. Number 3, despite all these medicines and tools in our hand, is ineffectively treated. Why? Part of the problem is dependent on your physicians.
Okay.
Part, patients, families. Many, many people come, and I ask patient, what was your blood pressure? Oh, my doc told me, well, fine. Do you know the numbers? No, he said just pressure is fine. Anytime you were told, what's the blood pressure? Of 150, 145, I say, you're hypertensive. In my books, even 140, 130 is hypertensive. Because the current recommendations is the ideal blood pressure. Don't you want to have your ideal blood pressure? Not normal. There's a difference between normal and ideal.
Okay.
Don't you want to have normal for you?
Definitely.
Everybody here wants to have a normal, ideal blood pressure.
Yeah.
Why shouldn't you?
Right.
In ideal blood pressure, the current limits are 115 to 120 over 70, 80.
Really?
Because if you look at the literature and the evidence, 1 to 2% decrease in blood pressure, 1 to 2 millimeter decrease in blood pressure, decrease from 5 to 10% morbidity and mortality. Imagine blood pressure coming from 150 to 130. Imagine the saving of your ears, saving of
quality
your
of your life,
complications,
yeah.
saving of your miseries, saving of your finances, saving of your family miseries. So it goes on and on and on. Blood pressure is just not a one entity.
No, of course.
Blood pressure is you,
And then that combined with somebody who's diabetic.
of course, because the same genes which encode blood pressure
Yeah.
also encode partially diabetes. So if you look at, I have the slides, blood pressure and diabetes go parallel. They never quit, they never leave each other.
Okay.
You have diabetes, the studies have shown
You're going to get blood pressure.
56% of the people ultimately you'll have blood pressure and vice versa, and diabetes. So, and then the same genes encode, which we were talking before the program, for your cholesterol problem, dyslipidemia. So now you have a blood pressure. You're 40 plus, you're 50, now you develop diabetes. Oh, it just, as you told me, I just found out, people say. And then you have a cholesterol problem. And on top of that, you have a weight loss, overweight.
Yeah, obesity, absolutely.
And then if you have a genetic predisposition that you're male and your family has a history for what you're going to do, where you're going to run away. You can't run away.
You can't be an ostrich anymore.
So the only thing you can have, modify it.
Right.
Head-on collision with this one, because you're going to ride on top of this one. Don't let them ride on you.
Absolutely. Dr. Amjad Butt, thank you so much. Unfortunately, we've run out of time, and it's been a really, really informative program. And I'm sure the viewers have learnt so much from our sit-down today. If you, just before we go, a very, very brief message to our viewers, please.
Don't just sit home. Come to doctor. Talk to them. Just don't take it for granted. It can't happen to you. No, it will happen because you don't have a steel walls around you.
Oh, exactly.
You're not immune to this one. And these commonest problems are avoidable, treatable. All these miseries can be avoided.
Right, absolutely. Prevention is better than cure, of course. Thank you very much for being part of the program.
My pleasure.
Okay, and with that, we come to the end of today's program. Hope you have enjoyed watching and been as informed as I certainly have been with our expert. So the main thing is prevention is always better than cure. Keep that in your mind. Until we meet again next week, stay happy, stay healthy. Bye-bye.